Good morning, everyone. My name is Kim, and I will be today's webinar moderator. Welcome to today's webinar entitled Early Palliative Care Involvement in BMT, presented by Dr. Kevin Weingarten. Dr. Weingarten is a physician on the Pediatric Advanced Care Team at the Hospital for Sick Children in Toronto. He splits his time between PACT and oncology, where he attends on the blood and marrow transplant and leukemia and lymphoma services. After completing his residency in pediatrics, he went on to do fellowships in pediatric hematology and oncology at Sick Kids Hospital and pediatric palliative care at Boston Children's Hospital. Dr. Weingarten also completed his master's in bioethics at the Joint Center for Bioethics at the University of Toronto. He is currently the Fellowship Program Director for Pediatric Advanced Care Team. Before we get started, I'd like to briefly go over the format for this webinar. There will be two parts, a 45-minute presentation segment and a 15-minute question and answer session. All phone lines will be placed on mute during the presentation. You may post written questions during the webinar by using the chat box located to the right of the slides. After the presentation, Dr. Weingarten will answer all written questions. When there are no further written questions, I will take questions by telephone. Should you experience technical difficulties, an operator can be reached by pressing star followed by the 0 on your telephone. At this time, I would like to present to you today's speaker, Dr. Weingarten. You may begin your presentation.
Hi, everybody. Thank you so much for inviting me to give a small chat on early palliative care involvement in the bone marrow transplant world. As you can see, hopefully by the end of this, we'll all realize that bone marrow transplant and palliative care are not like oil and water, and I hope over the next 40 minutes or so, we'll be able to convince you of that. So, I have no disclosures, no real conflict of interest, other than the fact that I work in both areas of palliative care and bone marrow transplant, and therefore I guess there's a slight conflict of interest in that to make my life easier, I'd love for these two groups to get along even better than they already do. So we'll start just briefly with the case. This is a composite case made up. It doesn't have any identifying personal health information. So our patient is a 14-year-old male who has relapsed leukemia after a first bone marrow transplant. The leukemia and lymphoma docs have currently got him into a morphological remission, and he's being assessed for a second bone marrow transplant. And I think part of what I want to get at today is really what does it mean to be assessed for a second bone marrow transplant or assessed for transplant in general. And of course, the real question that I want to ask is that should we call palliative care? And we're going to get into that in some detail. But keep in mind this case just as we go through the rest of the presentation. So because I'm a palliative care doc, I'm supposed to have a slide on objectives, of course, but I like to call them goals, and as we are a goal-oriented team. So hopefully we'll be able to explore the relationship between palliative care and bone marrow transplantation, debunk some myths regarding palliative care and maybe BMT as well, and then we'll finish up discussing some strategies that have been tried in North America for early palliative care involvement in the bone marrow transplant world. So I probably don't need too much time to talk about bone marrow transplant to this group, but when I was thinking about this presentation, I started by asking myself, well, how do you describe bone marrow transplant? And for the purposes of this talk, I'm including all hematopoietic stem cell transplantations. Now, obviously, we have a conditioning regimen where we use radiation and chemotherapy and antibodies, and then we give some cells. Either if it's in this diagram, it's an allo transplant, but if it could be your own cells back. But I think really it's in some ways more complicated, but in other ways much more simple. The perception of bone marrow transplant. And for me, when I think about it just in one word, I think what ends up happening, and for many families this is true, and I know for many clinicians as well, that the perception really is that of cure. The bone marrow transplant is It's a complex process where there are a multitude of healthcare providers that are doing many, many things at the same time. However, I think if you boil it down to it for, like I said, families and clinicians and patients, what we're really talking about is a chance for cure. And I think that's an important thing when we start to talk about the relationship between these two, that this initial impression is one that's there. And I did the same thing when I thought about palliative care. And there are lots of models that have come out over the last, I would say, 4 decades or so about what palliative care really is. The one at the top corner of the slide is one that has historically been quoted, where you have a patient who has active care, otherwise you can think about it as curative intent therapy, and then something happens, there's a switch that goes off, and all of a sudden you're in palliative care, and then the patient dies, and then that's it. Another image of it is this painting on the right-hand side of the slide, where there's this feeling that you have to choose between cure, in this case, the perception of cure with bone marrow transplant, or you go to the dark side, palliative care, death and dying. And of course, we don't think of it as a dichotomy in palliative care. We think it much more like this last diagram, which we'll go into more detail later. But basically, there are parallel processes that are going around. And really what we're doing is goal-oriented and goal-directed care and individualized care plans along the way. And things continue going on even post-death. But for all the time that I spend on this slide or talk about palliative care, just like I did for bone marrow transplant, when you think back about what the initial impression is, and this isn't just the lay public or patients and families, this is clinicians as well. The main perception is still that of the Grim Reaper, death and dying. And we say it tongue-in-cheek, but it is a pervasive feeling that impacts the way people refer to palliative care and the way that they think about palliative care as a specialty and as a philosophy of care. And so, if you think about bone marrow transplant and palliative care in these very simplistic terms, and I know many of you out there don't, but there are many people that do, then anyone would choose cure over the Grim Reaper. And I think that part of the reason that I wanted to do this talk was really to break down these images. There are definitely parts of it that are true. BMT is definitely the last option for cure in many, many cases. And a lot of the time, the palliative care team does perform some elements of end-of-life care and taking care of families into bereavement. But I think instead of this image, what we should really think about is perhaps something that looks more like this, which is two things that generally aren't associated together, but really, really belong together, as you can see there. There's no particular reason why I chose palliative care to be the dog and BMT to be the cat. I just thought it was a cute picture, and it helped illustrate my point. All right, so in terms of how we go about doing this and how do we talk about these things in more detail, of course, I think we do need to talk about BMT in some more depth and palliative care. But then I think the good stuff is in the middle. I'm a big cotton candy fan, so as you can see here, I think it's the good stuff of this talk and really of the relationship is how we intersect and how we forge together as two teams that can support families through a difficult journey with serious illness. So I think, as I've mentioned, bone marrow transplant should be associated with more than just cure. It has been thought, these quotes are from different papers in the literature, but I think they ring true just on spec. So it's an intense, cure-oriented setting, and I think that this is something that is obvious to us, but what comes with it, there's many things that come with it. There's significant risk of morbidity and mortality. There's a heightened symptom burden, and in some studies, and a lot of studies actually, have shown that significantly decreased quality of life as well throughout the transplant period. In terms of how the BMT patients are in comparison to the general hem-onc population, there are some important differences. The BMT population, as I mentioned, is an intense environment, and they receive much more intense therapy. It has been found that resuscitation status discussions happen later amongst the bone marrow transplant group. There's more frequent deaths in the intensive care unit. There's less opportunity for location of death to be planned. And in the U.S., it's more of an issue than in Canada with the way their hospice system is structured. But there's less hospice enrollment as well for those patients and families that are in the bone marrow transplant world as compared to the hem-onc population. Also, around death, it's more common that we see intense therapy amongst the bone marrow group. And some of this has been ascribed to BMT physicians and clinicians in general having to confront sudden and rapid changes in their patients. There's this feeling that there's an unpredictable disease trajectory, and there's a strong focus on cure, as I mentioned right off the bat, and a reluctance to forgo curative therapy. And that's really everyone. That's clinicians and families involved in the whole bone marrow transplant population. And even in bereavement, it seems that bone marrow transplant may also be different. And when you compare compared with general oncology population, bereaved parents this is a pediatric study, pediatric BMT recipients have higher incidence of traumatic grief, higher rates of depression, stress, and anxiety. So I think that there's probably some people out there that are maybe screaming at their computer saying that's an unfair characterization of bone marrow transplant. And in some ways I agree. I think that bone marrow transplant is a really, really tough thing to do. It's really hard to prognosticate, and this was true even before we had newer therapies that are coming out, including biologics, immunotherapy, CAR T cells, and others. The clinical course can shift rapidly, so you may think that you have a great understanding of a clinical situation, and all of a sudden things can change at the drop of a hat. And this idea of a dying point, the recognition of a dying point is difficult. So there are patients that get so sick through transplant, and we expect that. And so to actually determine when the point that someone is actually dying and not just having some significant morbidity from the bone marrow transplant or a complication that could be treated is really, really difficult. And this is true even if the factors of poor prognosis are clear, and some of those being multiple organ dysfunction. So it's a really, really tough job. And I think what that leads to is that we have a situation where we have high risk of morbidity and mortality, really tough prognostication, potentially a lower quality of life, and then this increased traumatic grief, depression, anxiety, and bereavement. And to me, that really just begs the question of why not have more palliative care involvement. This is a perfect setup for that, because palliative care really is meant to address a lot of these issues that BMT brings up. So I'll just spend a few minutes talking about palliative care, and again, not going into great detail, but just talking a little bit about how it might intersect with bone marrow transplant. So in general, palliative care focuses on well-being of patient and family with serious illness, and this is irrespective of goals of care or anticipated outcome. So it doesn't matter what the diagnosis is, what the prognosis is. Really what the goals are, our job is really to focus on the well-being of the patient and family and support them through whatever journey they are on. And again, I think that this is the graph, this is the diagram or picture that you should keep in your mind when thinking about palliative care, where for a while you'll have hope for cure, life extension, even a miracle. And of course that can happen right up until death. And even and you can see the line right at the bottom, there should be a hope for comfort and meaning, and that can continue on through bereavement and on. This graph, the only thing that I would change really is the fact that bereavement care doesn't necessarily have to end like this. It doesn't have to come down with a sharp ending. But in the middle, as you'll see, and this is an important concept, that really is an individualized blending of care directed at underlying disease, whatever that is. It addresses all sorts of aspects of the child, family, or older patient. Of course, a lot of my stuff comes from the pediatric world, but this would be applicable to anyone. And you continuously reevaluate and adjust based on goals, based on clinical status, based on how families are feeling at any given time. When you look at some of the descriptions of palliative care out there, this is from the WHO, just to drive home the point further, it really doesn't have any mention at all of end of life. It talks about how you help families through really tough times in multiple facets. And so this is really part of the education that I feel obliged to do at any time I get to talk, is really to stop some of the mythology about palliative care being only about end of life. It's not how we define ourselves. It's not how we're defined in general. And palliative care, in specifically within bone marrow transplant, can really be useful in any scenario. So if a patient survives, then palliative care can play a role in symptom management, support overall well-being, and importantly here, we can support the team. This is a really important role, and I think it's a really underutilized role in general within palliative care and all services in the hospital, but specifically in high-intensity places like bone marrow transplant, where we can help address and maybe preempt some of the moral distress that comes with treating some of these really, really difficult diseases and going through really difficult times with families, because we all get attached to families and to patients and their families. And then if they don't survive, or perhaps if they survive but have significant chronic health concerns, then palliative care can be really useful in ameliorating suffering, identifying what the priorities, and if there is an end-of-life care that we're talking about, to really delineate what those goals might be. So after I went through these slides as I was preparing this, to me the reaction really is, well, this seems like the perfect setup, and I was scratching my head. For those of you, because it's not a webcam, you can't see me, but this is how I look. And I was just scratching my head, and I was wondering, well, how come this doesn't happen more? How come we don't have more organizations, institutions that have a real collaborative relationship between palliative care and bone marrow transplant? Of course it exists, but not in, I think, a comprehensive way. And I think part of that has to do with what we talked about right at the beginning, which is the misconceptions that have come out of years and years of myths and half-truths about the two groups. So this is from 2015. The American Society of Hematology published this paper, and they talked about how palliative care perceives this as stem cell transplantation, the bone marrow transplant group, and vice versa. So if you look here, palliative care, this is how they were misperceived, that disease is the enemy, death is failing. This is how palliative care people think of the bone marrow transplant. It's protocol-driven. It ignores suffering. It could mean torture. You don't communicate with patients or inform them of risks. And then vice versa, the feeling that the bone marrow transplanters had of the palliative care crew were that suffering is the enemy. A bad death is failing. There's no good science. We ignore cures. Palliative care means giving up. All talk and no action. And we try to talk patients out of life-saving treatment. I think that both of these groups couldn't be further from the truth. And they fueled this canyon, as they refer to, fueled a lot of myths and barriers for palliative care and bone marrow transplant, really connecting until really recently. And so some of those myths and barriers include the fact that this is a truth that oncologists are less likely than other specialties to consult palliative care. Oncologists have a negative perception of palliative care team involvement. In some studies, they were quoted as being mutually exclusive, and this was probably just one ill-informed clinician, but thought that palliative care were seen as death squads with no place in a cure-oriented bone marrow transplant program. That's pretty harsh, but came from the study listed there. And then there were some providers in the study that actually felt that families needed to suspend their need for quality of life during bone marrow transplant. So this is a cure. You just suck up everything that's going to happen, and we'll worry about that once we're through the rough part of it. But this has actually, common sense would tell us that this wasn't true, but there has actually been recent evidence that refutes this as well, which is good to have some literature backing up the common sense here, that quality of life is going to be an important factor no matter what families and patients are going through, even if it is really cure-oriented. The next couple slides come from a table from the article listed here, which is actually where a lot of the information for this talk came from, and it's a wonderful summary about palliative care and bone marrow transplant, specifically in the pediatric world, but it's again applicable to everyone. And so it's a busy slide, and I don't know if it comes up that well, but I'll just focus in on a couple of things. The first one is a myth that palliative care teams convince patients to forgo curative treatments and focus solely on comfort. And again, I think that the gut reflex tells you that that's not true. But on the right side of this graph is a really important statement that the palliative care agenda, if palliative care has an agenda other than what the families is to begin with, is really to support goal-concordant care and attend to patient and family well-being. And so, those of us that work in palliative care, we often find ourselves advocating with families and with other care teams for further intensive or invasive therapies, cure-directed, intensive therapies. Because underlying all of it is the idea that what we want is goal-concordant care. We want to be able to figure out what the goals of the family and patient are and support that. That's a really important point. The second one from this part is that early palliative care would convince families to forego stem cell transplantation or cause them to lose hope. And this also has been looked at in studies, and in fact, where palliative care has been involved, it has not caused anyone to actually not go for transplant. And this issue of hope has been looked at in a variety of ways within the transplant world and in oncology, and really does not hold any water. If anything, it helps identify what the hopes are for a patient or a given family. So the second half of this, again, it's really big. I'm actually only going to look at, I think, one thing, which is that the myth is that the bone marrow transplant team knows the patient and family well, and a second team wouldn't add anything. Well, what we've found in palliative care is this, that many patients and families believe that they enter an agreement with their team that's trying to cure them, and that sharing doubts and fears is difficult for them. You can imagine if you had a partnership with someone and your job was to try to fix the problem, you may not want to tell them everything bad because you may start thinking that they won't want to fix it as much because they think that you're giving up or you may not want it as much. And so when I'm doing the palliative care bit, I'm amazed because families will sometimes talk about things that they haven't told their primary care team, and it is not anything to do with the individual person that's in the room, but more of the fact that I'm not part of their direct primary care team, and I think there's less feeling that they have that we might change their care plan if they actually are honest with their fears and doubts. So having an outside team that's not directly associated with decision making actually I think is a huge advantage. And for those places that are lucky enough to have a specialty palliative care team, it's something that really begs us to support that team and allow it to grow. And so then, like I said, just really recently, but there have been a bunch of partnerships between palliative care and bone marrow transplant in more formal ways that are cropping up, and then there's been studies on this, both in the pediatric and adult systems, where there's been really successful integration and success based on patient outcomes, but also clinician feelings about those outcomes. As you can see here, there's also improved patient and caregiver outcome, including improvements in depression and post-traumatic stress disorder after bone marrow transplant in patients and their families, and a decreased reduction, sort of a double negative there, in quality of life post-bone marrow transplant. So I think it's a lie to think that palliative care will get involved and during a transplant quality of life is actually going to get better. It's really intense and bad things happen during bone marrow transplants when you don't have an immune system and you're at risk for infections and all other sorts of complications. But there's a reduction in how far down that quality of life goes when palliative care programs have been integrated more formally with the bone marrow transplanters. Okay, so the question then becomes, well, how do you do this? Are there any models out there? And luckily there are. There are a number of models out there. I'll go through 4 different models in some detail. The first one really is just the way that it has always been, which is a primary team, the bone marrow transplant team, would initiate a consult whenever they felt it was needed. Something called a trigger-based consult service, which we'll get into a little bit. A universal tiered, which I think is a really interesting model, and then a universal, which is sort of self-explanatory, where everyone going through bone marrow transplant would see the palliative care team. So in the traditional primary care initiated consult model, you can have it with or without provider proximity, and I'll describe that in just one second. Without proximity just means that the palliative care team is doing their own thing, and there's not any formal time for the 2 teams to really meet. And then the bone marrow transplant team would just ask for palliative care consultations whenever the individual who was on service felt it was necessary, or they felt it was the right thing to do. With proximity is sort of I think, a first step along the spectrum of bone marrow transplant and palliative care integration. What it means and what it meant to the study that this came from was that there would be a formal relationship. So the palliative care team would be in the rounds either weekly or daily, depending on how much resource availability there was. And that allowed the palliative care team and the bone marrow transplant team to always keep this on their radar. And so probably there were more consults than there would have been if they didn't have this. It also allows for more education and collaboration with studies when the palliative care team is just kind of around in general through the bone marrow transplant program. Of course, we said it's the discretion of the primary team, which there's a risk of missing some patients who might benefit from this. And generally, this type of model occurs after the start of bone marrow transplant, and probably even generally it occurs after there are complications in bone marrow transplant. As you can see there, the 2 circles of bone marrow transplant and palliative care are overlapping, but just a little bit. So the next one, and I probably shouldn't have put a picture of a gun there, but you get the gist of it. It's called a triggered consult, and these are done in different places. And the one example of an institution that does this is at Dana-Farber in Boston, and teamed with Boston Children's, and they have these triggered consults. And the triggers can be defined by the bone marrow transplant team in conjunction with the palliative care team, more from an institutional point of view, where there are certain things that put patients at higher risk and maybe higher need for palliative care service. So those things might be a second bone marrow transplant, like with our patients, if there's active disease going into transplant, if there's increased need for support, or if it's considered a high-risk transplant. And there's different definitions of this if you have multiple organs involved, or more formal index, like the comorbidity index, where you're taking into consideration multiple things and coming out with a number about how risky this transplant is. This consultation service also generally occurs after the start of bone marrow transplant. However, in cases like in the example where it's a second transplant or there's active disease coming in, then they may actually happen before as well. The third group, which I think is my favorite of the bunch, and not one that we do here at SickKids, but obviously would be one that I think would be interesting to try. It is called universal tiered. And so what this means is that every patient and family that's being assessed for bone marrow transplant would see the palliative care team. This generally would occur before the transplant, and this would be a screening consult. And the screening consult is really a get-to-know one another event. At St. Jude's, which is a research hospital in the States, what they do is they have a 30-minute consult where they have a structured consult that includes asking particular questions about the family and the patient. This also, the benefit of this system is that the trigger really is for the level of involvement, not the involvement overall. And so what happens after the screening consult is that if there are some high-risk things, just like in the trigger consult, then you move over and get a full palliative care consult. And therefore, the palliative care team reserves resources for those in the most need. So it's really the difference between the two is that everyone gets a consult, and the trigger is for the level of involvement, really reserving those for those who need it the most. And of course, this happens before bone marrow transplant, which again, I think there's an inherent benefit of getting to know families out of crisis. Finally, the last one is universal consult, where every patient is seen fully by the palliative care team, full resource. And this generally also would start at the start of the bone marrow transplant. Of course, as you can imagine, this is the most resource intense. And I think there are some criticisms of this model, mainly from both sides, really, that there's little flexibility as primary providers for the BMT team to decide who really needs this and who might benefit the most when they're looking at their ward as a whole or their program as a whole. So the question to me then came up, well, okay, you've got all these models, but what does a palliative care consult actually look like? And certainly this depends on whether or not it's part of that tiered system where you have a targeted consult or if it's broader. But generally, I think it's fair to say what palliative care teams would aim to do is a 30 to 60 minute focused consult, followed by some frequency of visits. And that might be every week or two. The follow-ups could include things including symptom management, family or sibling support, staff support, like I said, really important, and moral distress, to address moral distress. The consult generally would really explore the familial and patient goals, values, hopes, and fears. And like I had mentioned before, St. Jude actually uses these prompts specifically to go through questions like, what are you hoping for? What does a good day for you look like? What are you worried about? And how do you define a good parent? There's been a lot of research, and I listed one article here by Pam Hines in the States, really looking at, in the pediatric world, what it means to be a good parent and how does that influence decision-making with serious illness. And preemptive consults can include aid in decision-making. And this is a really interesting place where I don't think palliative care has really been involved in up till now, which is the idea that you get involved before the decision to go for a high-risk transplant is made, really exploring with the family whether or not they fully appreciate what life would look like with and without a transplant, and going into some detail and really normalizing their thoughts and feelings and fears and exploring potential futures that they might encounter if they did or didn't go for another transplant. So just in another way to look at this, and the pros and cons of these four systems, I think that one of the major considerations has to be the autonomy of the primary service. A universal consult really takes that out of the question. The trigger consult, I realize now it looks like it's mirror image, but the universal consult really is, the universal tier, is a really nice way of having a mix of allowing for every family to meet the palliative care team out of crisis, but then for everyone to really get together and determine who needs more. The trigger consult has a little bit more autonomy, which patients might need it based on a certain criteria that for sure the bone marrow transplants and palliative care team need to get together to get involved. And then the most autonomous method would be the old one, where I think most institutions still have, which is that it's the primary care providers that are just consulting based on what they feel is their need. Of course, resources are a huge issue, and as I mentioned before, as you go through the spectrum of models, you end up with a much more resource-intense situation. And for an institution, any institution would have other factors to consider, but it may be that an institution feels that everyone should have it, and to do that, then they need to pump up their palliative care resources. So it may not be a bad model for every group, but certainly those that have fewer resources, it would be tough. Another way to look at it is with the percentage of patients that may benefit or benefit the most. And in this line, I've reversed the universal and the universal tiered, because I think the nice thing that the universal tiered model does is it really figures out which families and patients are going to need the most. And so you're probably doing the most good for the most people rather than a blanket statement saying that you're going to see everyone and do the same thing for everybody. And finally, this is a really important point that it goes without saying really, but just to say it, that the amount of normalization of palliative care, so taking away some of those myths and fears about what palliative care represents, is much more likely if it's just built into the program, if it's just going to happen for every patient no matter what, and then of course if they get sicker then they're going to need it more, versus linking it to risk and prognosis. So this is typically how palliative care has been seen, that if you have a higher risk disease or a worse prognosis, then you'll have a consult with the palliative care team. So I think we do everyone a favor when we introduce the idea earlier, so that it can be seen as a normal part of the process of a really intense environment with a curative intent, but a really intense environment that is going to need a lot of support. So I think that overall there really aren't a lot of risks with early intervention. I hope up to this point convince you that some of the myths and barriers really aren't there or shouldn't be there. That palliative care is not really exclusively linked, should never be exclusively linked with death and dying, although of course that's a piece of what palliative care does. You can have more meaningful conversations out of crisis than in crisis. I think we all appreciate that. If we're talking about a potential future, you can explore it in a different way than if you're in the middle of a crisis, if you're in the ICU in a septic episode or organ failure. It can lead to earlier communication regarding prognosis and resuscitation, which then can have an influence on a less intensive therapy at end of life, including, there's good papers to back this up, fewer ICU deaths, fewer intubations, and then there's that sort of caveat that I think we all also just need to recognize that this is a really intense process and a really intense procedure and intervention, and that it doesn't lend itself very well for patients to die outside of the hospital. So that's just a truth I think we have to accept, that a lot of these patients will, if they die, will die in hospital, but that doesn't mean that we can't change their end-of-life experience, but certainly that doesn't mean that we can't change everything that precedes that while we're still aiming for cure. So, and just to bring it back to the case for a minute, the question that we started off posing was, should palliative care be involved, or should we call palliative care in this case with Peter Parker here? And I hope by now that the answer that you're screaming at your screen is yes. And I would say yes, but. And the but really is that the real hope for Peter in this case is that palliative care was already involved, that palliative care was able to integrate with him and his family and his care team throughout the process of bone marrow transplant, such that we could support him and his family no matter what happened, no matter what decisions were made. So like I said at the beginning, I didn't think this was going to run the full time, but I wanted to leave you with some take-to-work points, which really includes the first step in all of this is understanding each other, understanding BMT perspective of palliative care and vice versa, trying to break down some of those misperceptions and really figuring out a way how to work together best in your particular area with your particular geography and culture and patient makeup. Certainly, palliative care and bone marrow transplant are not mutually exclusive, and from my vantage point, it's really hard to imagine specialties that were more well-suited, a setup where there's high intensity, high symptom burden, lots of stress amongst families, patients, caregivers, and a team who wants to help with all of those things. There's good literature out recently that shows that early involvement is beneficial to patients, families, and the staff. And I really think that our choice here is not whether or not we integrate or involve palliative care early, but it's rather how we do that. And with at least 4 different models to choose from, I think that there's probably one that makes sense for your given program or institution. So that's all for my presentation. I just wanted to say thank you very much. We had this was a picture through my son's telescope where There was the super wolf blood moon just a few nights ago. I hope you guys saw that. But that's it for my presentation. I'm certainly happy to move on to the question period. If there are any questions in the chat boxes, I'm happy to answer those first. And once we get through those, we'll take anything that is on the phone.
Thank you, Doctor. This concludes the presentation segment of the webinar. We will now begin our Q&A session by addressing questions submitted via the chat box. We will give participants a minute or two to submit their questions. After we have answered these, we will take questions by telephone. Doctor, are there any web questions?
Not right now, no.
And just a reminder, it's *1 to ask a question over the telephone. Again, if you'd like to ask a question over the telephone, please press * and the number 1. We'll pause for just a moment to compile the roster. I do have a question over the telephone. I'll open that line.
Hi there.
Please go ahead with your question.
Oh, hi, great presentation. I wonder if I could ask a quick question about how do you approach discussions around goals of care, code status, things like that for patients going through transplant? Can you give us some advice on how, for a curative procedure, the best way of sort of approaching that topic?
Sure. So I think everyone heard that, but the question was really in a cure-oriented setting, what are some tips that we may use when discussing goals of care, including things like resuscitation and intensive care with families. I think for us, our approach is similar no matter what the intervention is, and that is really to focus in on the current situation of harms and benefits, and really talk about the pros and cons of any procedure. And so there might be times where resuscitation would be beneficial because we feel like we can reverse something. It's just an acute complication that we can get the patient back to where they were. And so I think if there's a continual assessment for every intervention that we're doing for a given patient about the harms and benefits of that procedure, then it kind of becomes quite easy. And so we would talk about anything that way, including CPR, as I mentioned, that as long as something has more benefits than harms, let's do it, or let's keep doing it. And if something has more harms than benefits, then we need to either stop it or not do it to begin with. And I think with that type of approach and continual assessment of, does this still make sense? Do we still have more harms than benefits, or more benefits than harms? Then I think you can actually talk about just about anything with the family. The other thing that from a palliative care point of view that we do a lot is normalize things. So we talk a lot about how families, some families will come out and talk about all their fears and hopes and worries, but some families won't. And so what we do in those situations is say, would you like to hear what other families have been worried about at this point? That does a couple of things. It gets you a sense of what type of family you're dealing with, but it also gives you an opportunity to just tell them some of the things that you're worried about and that you've heard other families worry about before. And by doing that, it normalizes things and doesn't make them feel like there's anything wrong with them for having fears or doubts in a really complex, intensive situation. So I think those are two big strategies that we use, this idea of normalizing fears and worries and hopes for that matter, and also looking at the harms and benefits continuously for any intervention that you're doing. There's one question from the chat box. I'll just read it out. It says, how soon would you talk about hospice options for those families? That's a really interesting question because I think that, again, hospice in general could mean a program or a freestanding institution. If it's a freestanding institution, I think many hospices around, certainly from a pediatric point of view, also provide other types of care, so respite care, for example, or symptom management admissions. And I think we do ourselves a disservice in general when we link hospice only with death and dying. If there's an opportunity to introduce them to a hospice before that, that can be really beneficial. So for example, here in Toronto, we have a hospice, a pediatric hospice called Emily's House, and we've increasingly been using it for oncology and bone marrow transplant patients and their families who just need it as a place to stay in between their house and coming to the hospital. And it gets them used to that environment. So it's a long-winded way of saying that I don't think there's any checkpoint for when hospice should be introduced. I think that if the aura of a hospice can be removed, then the earlier the better. If they can be introduced to the staff and the physical environment of it before they actually need it, then I think that can really help as well. But again, I think it's one of those things that families probably do need some time to get to, depending on their state, where they're at, and really determining if you think and they think it would be more beneficial to them is a way to go about it. There's another question online here which asks, does a patient have to be full code to qualify for bone marrow transplant? So this is a really interesting question. It's one that I feel pretty strong about. Because we've had this question come up not just for bone marrow transplant, for solid organ transplantation as well, where can you be on the list for either high resource intense intervention or limited resource if it's an organ? Can you be on those lists with a limited or modified resuscitation status? So from a very personal point of view, I think that you can. Because I think that you may want the intense therapy up until a point. I think there are a lot of transplanters out there who feel a little bit differently, which is that it's a package deal, and if we're going to enter into the contract of a bone marrow transplant, we have to be able to use all the tools that are available. But I think there is a gray area and a nice middle area where you can still do a lot of intense therapy, but you don't need to do everything. I think it's very reasonable for a family and a patient to say, yeah, I want to go through the conditioning regimen, I want to give this a shot, but if I need to go down to the ICU and go on ECMO, that's not for me, and I would want to stop before that. So I do think that there's a middle area, and I think it probably depends on your particular group that would determine whether or not you needed a CPR status clarification before entering to a bone marrow transplant. But from a very personal point of view, I don't think it's necessary, and I think there are ways around figuring out what interventions make sense to go that have to happen within a bone marrow transplant, and which interventions would be reasonable for a patient or a family to say, you know, I've had enough. So I don't think, the short answer to that is, I don't think you have to have a full code status to qualify for bone marrow transplant, but then again, I'm not the one that's determining that at SickKids or anywhere else, really. That's it for the chat box for now. I don't know if there's anyone else on the phone.
I do have a question over the telephone. I'll open that line.
Hi, calling from Hamilton. Thanks very much for your presentation. Could you talk a little bit more about what is a palliative care team? So we would have 4 social workers at last count attached to our team. They see the patients before transplant, and I don't know whether it's tiered or certainly often or as necessary during the transplant and thereafter. Is that what you would call a palliative care team? Do they need somebody else? Should there be a palliative care physician attached to this team? And how does an outside, because we're not likely to get a palliative care team permanently on our team, I would imagine. How effective can somebody coming in from the outside? So it's a general question of defining a team.
Yeah, it's a really good question. How do you define a palliative care team? No, I don't know that there needs to be a particular structure. I think that, like I said, I mean, there's going to be different resource availability for different programs. There's been lots of successful programs for many, many years, at least in North America that I know, and here at SickKids and other places in Ontario, where it has been a single provider, and it has more often than not been a single nurse or nurse practitioner who has run the program. I think anyone can provide this type of care. Where I trained, we trained in a group. So there was 3 types of fellows. There was physicians, a nurse practitioner, and a social work fellow that trained together for a year in a pediatric palliative care fellowship. And I love that model. And what it spoke to is that we all have our specialties and we all have our areas of expertise, but we can all be generalists in each other's area. And I think in palliative care it lends itself to a multitude of healthcare providers from different backgrounds doing it. Now, that being said, I do think there is an advantage to having an outside team, and that was sort of one of the points that I had talked about in that chart, where if you have an outside team, there's something happens when you're not affiliated with the bone marrow transplant team or oncology team, or for us, if we're seeing patient for heart transplant team, there's something that happens when it's a team that's outside of, perhaps it can be in name only. But something that happens when there's a palliative care team or a supportive care team or a quality of life team or whatever you want to call this team. For us, it's PACT. Something happens where families let down their guard a bit, and you're actually able to get at a lot of things that you might not tell your primary team, like I said, because there's this feeling of we're in this together to cure, and if I show any fear or doubt, maybe you'll show some fear or doubt, and maybe you'll hold back on the best therapy, and all of these things are, of course, not necessarily rational, but those are feelings that we have and that we see, and there is something about having a separate team that time and time again find that families will have a consult, palliative care team will have a consult, we'll go tell the primary care team some of the stuff, and they'll be like, we've never heard that before, and we've talked to them forever, and it has nothing against them at all. Like I said, it has nothing to do with the people or the skill involved in communication. It really has to do, I think, with this idea that you have this outside team. So to me, the real definition is to have a group of clinicians, however you want to define it. I think having someone with a medical background, a nurse or a physician, is helpful to wade through some of the medical questions that a family will inevitably ask. They always ask, no matter who they're talking to. So I do think there's some benefit there. But I think more than anything, I'm becoming more and more entrenched in this idea that having a team outside the direct caring team is really, really important. Okay, no more in the chat box. Kim, I don't know if there's anyone else online.
I have no further telephone questions at this time. Since there are no further questions, we will now conclude the webinar. Once again, we would like to thank you for joining today's webinar presented by the CBMTG. We would like to inform you that the webinar evaluation will be sent to you via email following this presentation. Please note that this is a CME accredited event and that you will receive your certificate of attendance upon completion of the webinar evaluation. We hope that you have enjoyed today's webinar. The next CBMTG webinar will take place on February 13th, presented by Dr. Jorg Kruger, entitled CAR T Cells, A Pediatric Perspective. Thank you all for joining us today, and sincerely appreciate your attendance.